Hello everyone, good evening. Welcome to Conceptuals. I'm Dr. Purvi Agrawal, and today we'll be dealing with the topic of UPT positive. So let's start. Now, okay, so what is UPT? So UPT, also known as urine pregnancy test. Now, what happens in this urine pregnancy test? So, first of all, it is very sensitive to beta-hCG. And we can easily do it through a kit. Now, these kits are easily available in the market, and almost the cost price is around 50 to 100 rupees. Moreover, we do not need a prescription for this kit. And government hospitals even provide it free of cost. So definitely the patients half of the time will do this pregnancy test and then come to you. Now getting a UPT positive is where the dilemma starts. So today we'll be dealing all the concepts of this UPT positive. Now, what is this kit? So usually you get a plastic kit in which you have a strip where you have test and control. And here the patient puts their urine. The urine gets absorbed here and then you get a result. Now, if you just get one single line in the control, this is UPT negative. If you get two lines in the control, it is UPT positive. Now, it should be assessed at interval of 3 to 5 minutes and not later than that, because if at all there is a late faint positive, it might be a false positive test. So now we'll see what is the mechanism of action of this UPT kit. Now it checks for hCG, beta-hCG, free beta-hCG, and you have to remember that it is sensitive to as low as 25 milli international unit per ml of beta-hCG, per ml of blood. So even if there is slight indication of pregnancy, ये test positive आ जाएगा. Now what happens in this test is, so just remember, for the color to come as red, there should be a completion of circuit. क्या होता है वो circuit में? Now this is positive line. You have antibodies for hCG. These are anti-hCG antibodies. Now, then in the urine, you will get hCG, which will be binding to, again, anti-hCG antibodies. Now, this is something which produces a positive result. Now, what happens if at all this is your hCG and this is your anti-hCG antibody? All right. Now, if I have a test strip and a control strip, your control strip will already be having hCG stuffed into it. All right. Now, my test strip is having anti-hCG antibody stuffed into it. This is the thing which kit is already having. Your test strip has anti-hCG antibody and your control strip has beta-hCG. Now, अगर मेरे यूरिन में hCG मिल जाता है, so what happens? This hCG will bind to already present anti-hCG antibody in this area of the kit. So if at all you have urine में both antigen and antibody here, this will go and join here and the circuit gets completed. But in case the urine does not have antibody, this circuit is incomplete. So there won't be any hCG to bind these two antibodies, and the report will thus come as negative. Now, if at all there is already hCG here, this will go and bind, and the circuit gets completed here. So control will anyway come back as positive. So your control is always going to be positive because hCG is already there in that line of the strip. It just needs antibody to complete the circuit. And here, because already there is hanging antibody, hCG with the hCG antibody goes and completes the circuits. So if at all there is no hCG in the urine, the circuits gets incomplete and we have a negative result. Same way, if you have hCG, the circuit gets completed and then you get a positive result. Now, if at all you guys have any doubt, please put it in the chat box. Towards the end of the session, we will solve that, all your questions. Now, what are the benefits of using this kit? So I already told you, it is very quick. It gives you a result in 3 to 5 minutes. It is very easy to use. You can do it at home. You can tell your patients to do it at home. It is very cheap. You don't need a prescription for it. And most of the cases are reliable. What do you mean by reliable? It means that the false negative is very less. Moreover, it is non-invasive. So if I have a non-invasive test, obviously I'll prefer that. अब इसी का counterpart होता है, which is even more sensitive, is the invasive part, which is called as serum beta-hCG. Now, serum beta-hCG is a blood beta-hCG, which can even detect 0.5 milli-international units per ml. This one detects 25, this detects 0.5. So, which will come positive quicker? Your serum beta-hCG. So, if at all you have any doubt in your urine pregnancy test, go ahead and do a serum beta-hCG to confirm. Moreover, serum beta-hCG will give you a numerical value. So you always have the answer in numbers. Now, once your UPT is positive, you just know it is positive. Is it going good? Is it falling? Is it in the normal range? You cannot tell it by UPT. But serum beta-hCG plays a role there. All right. So, when do you do a UPT now? You know the advantages. Now, when do you do it? Now, the first and the most common indication is missed periods. All right. Now, second common indication is the patient has not missed a period, but there are signs and symptoms of early pregnancy. Third, the signs and symptoms are suggestive of an extrauterine pregnancy. So, for example, if an unmarried girl comes to you, she might not give you the history of a missed period, but then she might give you a history of pain abdomen, and she's in that age group where they can be sexually active. You have to do a UPT in these cases. Now, what is the next common indication? You have to do it for all your obstetric practice, be it married or unmarried, where you suspect any kind of signs and symptom, most commonly being pain abdomen. So you should not restrict your UPT only to married. You should do it for unmarried also, because missing an extrauterine pregnancy might cost the patient their life also sometimes. Now, what happens next? Now, when you have a high beta-hCG, it might not always mean a viable intrauterine pregnancy. All right, so look at the words. Viable intrauterine pregnancy. First of all, apart from pregnancy, where else can you find a positive UPT? So, in extra uterine or intrauterine pathologies. These are rare, but they can always happen in cases of extrauterine ovarian cyst. Mostly they are seen in the younger population, and you can also see it in some kind of tumors. Also, if you have externally administered injection दिया है beta-hCG का, for some reason or the other, it might also come as positive. So, all these things you have to rule out before telling that the patient is pregnant. Moreover, beta-hCG splits during summers. तो गर्मी के मौसम में a beta-hCG can be falsely high. Now, when you have a high beta-hCG, just make sure that the sample which was taken in good, friendly environment, that is cool, dry places. And also, you should make it a habit that जब भी आपका sample collect हो रहा है, tell the phlebotomist or the lab personnel to keep it in dry places. This will also help you to prevent a falsely high beta-hCG in your dual markers. Because a high beta-hCG in a double marker is actually an indication for T21. So you can prevent a false invasive or maybe the cost cutting for NIPT just by storing your beta-hCG samples in cool dry places and not in very much of hot temperatures. Now, what next? Your UPT is positive and you find out that it is because of pregnancy. You have ruled out every other cause. So you have to remember, we are blessed to be in India. Why? Because in foreign countries like UK and USA, where the positive pregnancy is not an indication for scan. Why? Because there the government funds their entire medical practice. सारा पैसा insurance से आता है. The patient pays insurance to the government and the government has to fund their entire medical services. India में ऐसा नहीं है. You do not have to be dependent on government until unless the patient is coming to a government hospital. So you have private hospitals and you can do a scan immediately after the UPT comes positive. In UK and US, they scan only when there are some signs or symptom of pregnancy complications. Otherwise, when you read their guidelines, they will tell your NT scan or early anomaly scan is the dating scan. So what they do, they only scan the patient in emergency. But we do not have to follow their guidelines in these cases. Why? Because in India, there are no guidelines and we should scan the patient as soon as possible. So what is as soon as possible in our scenario? Now, a patient has come with UPT positive. Usually, this UPT positive will be somewhere around 5-week plus. Very rarely they do a pregnancy test before 5 weeks. Now you have to understand, 5 weeks में serum beta-hCG is equivalent to somewhere around 500 and latter weeks of 5 weeks में हो जाता है 5000. है ना? तो UPT आपका पॉजिटिव आ ही जाएगा. अब जो ट्रांसवजाइनल स्कैन होता है, ये सैट कब देखता है? जब आपका beta-hCG 1000 इंटरनेशनल यूनिट्स है, मिली इंटरनेशनल यूनिट्स पर ml. और TAS आपका कब पकड़ने लगेगा? जब यही चीज 1500 हो जाएगी. तो आपका UPT पॉजिटिव अराउंड 5 वीक्स है. So somewhere around maybe 5-week 2-day or 5-week 3-day, आपका beta-hCG 1000 हो जाएगा, and then you can definitely make up the sac in a transvaginal ultrasound. Now, with this, I want to tell everyone that the gold standard for diagnosing an intrauterine sac is a transvaginal scan, and transabdominal should be used only judicially if at all the patient is not agreeing for a transvaginal scan. But as far as possible, you should definitely try the patient agrees for a transvaginal scan, because it gives you higher frequency, better resolution, and early detection. All right. Now, for our male gynecologist, you should always remember that the USG room has some rules when you're doing a transvaginal scan. The first and foremost is you should always have a female attender. Second thing is male doctors should avoid probe insertion. It should be done by the female doctors or female attenders. Third thing, the bladder should be empty before the scan. Fourth thing, you should make the patient very comfortable, and you should explain the procedure in advance. Fifth thing is, either there should be a lithotomy position or pillow under the back. Next is, you should never, male doctors should never be alone with the patient, be it TAS or TVS. There should always be one more person, either the patient's family or any female attender. These are the basic rules which everyone should know. So any male should not be performing the transvaginal or transabdominal scan alone, and definitely they should not be inserting the probe. Everything should be done by the female attender or the female doctors. All right. So now let's come to our main topic. Once you do a UPT, you get it positive. Then what next? You do a transvaginal or an ultrasound scan, and then you have two things. First thing is you see an intrauterine sac. Second thing is you do not see intrauterine sac. So this is to very happy. Intrauterine sac is there and we are very happy. This is where the problem arises. Intrauterine sac, no intrauterine sac, you go and you look for Adnexal. Now we'll come to this part later. Let's first do the easy happy part. Now, if at all there is intrauterine sac, you have to make sure if it is true sac or a pseudo sac. Got it? So now, आगे क्या करना होता है? What do you need to see to declare that it is a true sac? You have to see a yolk sac inside the sac, a fetal pole, one of them, either a fetal pole or a yolk sac, or a double decidual sign. Now, what is this double decidual sign? For example, this is your uterine cavity. This is the outer surface of the uterus, and this is the cavity. Now, this is the endometrium. So, endometrium then becomes your future decidua. All right. And this part of the decidua is called as decidua parietalis. And then you have the gestation sac here. This decidua is called as decidua capsularis. And inside this will be your gestation sac. Inside the gestation sac will be the yolk sac, and then we have the fetal pole. So what is the double decidual sign? Double decidual sign is the presence of two decidua, that is the decidua capsularis and the decidua parietalis. So I should be seeing two layers, 1 and 2 outside the sac. The sac wall does not count to be one of the layers. All right. So this is what the double decidual sign means. End of the lecture, I'll be showing you few images of the ultrasound. So stay tuned. All right. Now, in case of a pseudo sac, the first thing is you will not see a yolk sac. You will definitely not see a fetal pole, and you will not see a double decidual sign. You might see just a cavity and a small tiny structure. You will not see these two layers. All right. So you need, both the lines outside the sac, which is very important to be seen. Here, none of the line. Maximum you'll see one extra apart from the sac. The outer layer, outer covering of the sac, which is actually hyperechoic in nature, will not be seen. So once you have done this part, now you have the sac. What else can you see? How will your assurance become better? Now, in case if you have this is the intrauterine sac, which I have seen. All right. This is a yolk sac. This is called as ring appearance of the yolk sac. Yolk sac should be circular. You need not measure the yolk sac, but the presence is enough. Yolk sac is a structure which will give the fetus its nutrition before the placenta takes over. So if you see a yolk sac, it is actually a very good sign. Then you see a fetal pole. And then you see somewhere in between the cardiac activity. The best thing is you see everything. If you don't see anything, then you have to wait for them to grow. Now, in case of a pseudosac, what do we do? You also do Adnexal evaluation. All right. Now, if you have a true sac or an intrauterine sac, you confirm that there is definitely a normal pregnancy, or it can be something called as heterotopic pregnancy. Now, what is a heterotopic pregnancy? In heterotopic pregnancy, there are two sacs. One is intrauterine, and the other one can be ectopic. Now, this ectopic can be anywhere, intrauterine, intracervical, tubal, ovarian, anything. So, even if you see a good intrauterine sac, you definitely need Adnexal evaluation. So, Adnexal evaluation has to be done in all the cases, be it intrauterine pregnancy, be it extrauterine pregnancy. Now, once you get a normal pregnancy and you know that there's only one sac, what next? You need to see the sac in relation to the uterus. That is, where is it placed? Now, there can be three placements. First is placed centrally. Second is eccentric. Third is low lying. Now, if it is placed centrally and if it is single sac and Adnexal is clear, You reassure the patient, send them home. If it is eccentric means somewhere apart from center. So you have types in eccentric pregnancy. First is angular pregnancy. Now, as the name suggests, it is present in the angles, either right or left. What is the problem with angular pregnancy? Usually they turn out to be fine, but 20% of the cases, they might have bad outcome. They might bleed. They might end up into miscarriage. 80% do very well. So you just have to be cautious for these people. No progesterone will work. Nothing extra has to be added because it is just the fate. If it grows this side, bad outcome. If it grows this side, good outcome. So your progesterone is not going to govern which side it will grow. Triangular pregnancy, just wait and watch. Next is interstitial pregnancy. So this is in the interstitial part of the myometrium. So here is what you get, an interstitial line sign. In the USG, you see a line, thin line of myometrium, which is hyperechoic, which is outside your endometrial cavity, and it just lies lateral to the cavity. So this is called as interstitial pregnancy. Now these have ulta. 80% will have bad outcome, and the other 20% does not have a good pregnancy, but it might vanish, might get reabsorbed. But this 80% bad outcome is torrential bleed. All right. So you have to be very careful. The third place where there can be eccentric location is a uterus which is not having a normal shape. That is a bicornuate uterus with a pregnancy. So what will happen? Because the uterus has two horns, two cornus, it will not be placed centrally, it will be eccentric in location. Or if the uterus has a septum and it has not implanted here, it has implanted here. So this also can be having an eccentric location. All right. Now next, let's come to a low-lying sac. All right. In cases of low-lying sac, that means the uterus is empty and the sac is somewhere here. So either it is a cervical pregnancy or it is a previous scar pregnancy, or it is in the process of expulsion. That is incomplete miscarriage. So if at all, how do you differentiate between all these three things? I'll tell you. So if at all you have a cervical pregnancy, what will happen? The pregnancy is fixed here. All right. So it will have vascularity all around it. The cervix will become hourglass shaped. All right. And there's something called a sliding sign. What is a sliding sign? When I am doing a scan, my probe is here in the vagina. Now I push the pregnancy and I see, is the pregnancy moving with the uterine surface or not? If they are both moving together, that means that it is not sliding upon the uterine or cervical wall. That means sliding side is negative. But if they are moving in opposite direction, अगर मैं पुश करती हूँ और सिर्फ सैक मूव करता है, मतलब वो स्लाइड हो रहा है, that means your sliding sign is positive. अगर प्रेगनेंसी सर्विक्स में ही एम्बेडेड है, So it will not move in different direction, rather it will move with the cervix. Because if I give a push from here, both of them will move together. That means sliding sign will be negative in cases of cervical ectopic pregnancy. Very important point to differentiate. Similarly, in cases of a previous scar, now this is a sagittal view. This was from the front, which I look at. This is from the lateral sagittal view. Now, if in case the pregnancy is embedded in the scar, so what will be the, how will you get to know that it is a scar pregnancy? Sliding sign will be again negative. Uterus will be empty. Cervix will also be empty, and thus pregnancy will be in the lower uterine segment. And definitely there will be history of a scar. Either she'll be previous LSCS or any kind of uterine scar, surgery, anything which is done before. Now, why are we so scared of scar pregnancies? Scar pregnancies can also have two fate. Either it grows this side or it grows this side. If it grows this side, this might become adherent placenta. But if it grows this side, this might actually rupture. So, a diagnosis of scar pregnancy can actually prevent uterine rupture, can actually present adherent placenta. So, your entire placenta accreta spectrum has happened because the pregnancy got embedded in the scar niche, right? Now, what is happening in expulsion or incomplete miscarriage? Now, here, because this was the uterus and somewhere here is the sac. Now, the sac has started to expel. So, first thing first, your vascularity was supposed to be here. So, when you put color in ultrasound, you will not see any vascularity around the sac. Cervix will not be barrel shaped, but in fact, the sac might be irregular shaped because it is in the process of coming out from a narrow place. Third thing, when I put my probe and demonstrate the sliding sign will be positive. Why? Because here if I push the sac, it might go up and down and the uterus might not. So positive sliding sign with a low-lying sac will give you the diagnosis of incomplete abortion or miscarriage. Now, sometimes your UPT might be positive and the patient gives history of expulsion. So you might not get anything at all because your incomplete has now become complete. But UPT is still positive. Why? Because it takes almost 3 weeks for the UPT to become negative completely. So a patient should be taught in cases of incomplete or complete miscarriage not to repeat UPT at home. Because ये टेंडेंसी होती है कि यार प्रेगनेंसी तो गिर गई, हम एक बार घर में चेक करके देख लेते हैं. But they should be taught that they should repeat the UPT only after 3 weeks. Now coming to next topic. Now this is our intrauterine pregnancy. Now let's start our Adnexal evaluation. Now, what will happen in Adnexal evaluation? You can get 3 things again. First is, you go to the Adnexa, you see a sac. You see a sac with yolk sac, or you see a sac with fetal pool. Then you're sure that it is something in Adnexa, and you're sure that it is not an intrauterine pregnancy. Rather, it is an ectopic pregnancy. Second thing is, you see adnexal mass. You don't see a definitive sac, but you see a mass, something like tube ovarian mass. So you see something is there in the adnexa. It is not completely free, but you definitely see something abnormal. So you see an adnexal mass. And the third thing which can happen is you don't see anything, nothing intrauterine, nothing adnexa. So what do you call these things? Still UPT positive. You tell them, you label them as pregnancy of unknown location or PUL. Now this is where we get a little more confused. What to do with these PUL? You have to do a beta-hCG for them. Now this beta-hCG can either fall, and if it falls more than 15%, so this might have been a failing PUL. But because it is falling, we are okay. Even if it was ectopic, we are okay. So what do you do with this failing PUL, falling beta-hCG? You follow them up weekly till the time your hCG is less than 10 milli-international units per ml. Once it is less than 10 and with a falling trend, unlikely the patient is going to have any problem. But if you have a rising hCG, right? But it is rising more than 66%. See, here I'm not telling 66 units. It is 66%. So what do you do when it is rising more than 66%? You might actually be looking at an intrauterine pregnancy. बस ये हो गया कि अपन ने उसको स्कैन जल्दी कर दिया और अपने को मिला नहीं. So at that particular day when you have scanned and you didn't find anything, you do an hCG and then you repeat it after 48 hours. A 66% increase in your hCG will give you the answer that it might be an intrauterine pregnancy. And then the same thing, you follow up weekly. Now you don't have to follow her up weekly with beta-hCG. Why? Because you have a powerful tool called as ultrasound. You do ultrasound, and if at all after a week you see intrauterine pregnancy, you can be fine. Now, what is the problem here? What if it is something in between these two? So in between these two is query ectopic. Now this query ectopic is what you have to diagnose. What you will do? You will do a beta-hCG, you know, and you have something which is nearly maybe 500. Okay, क्योंकि अगर 1000 से ज्यादा होता तो सैक दिख जाता. 1000 से कम है, 500 के आसपास मान लो. You have to follow them up till the time the beta-hCG is 1000. Now you have to understand this is rather safe zone. 1000 is good number because till here you can give them medical management of methotrexate, and after this you can do TVS and diagnose the sac. तो अगर हमारा 1000 है, in fact methotrexate भी नहीं, you can do an expected management. So both options are there. 1000 के आसपास you are playing safe. So you don't have to diagnose ectopic before 1000. Wait, anyway it is increasing at a slower pace. Wait till 1000. 1000 आ गया, then you do a TVS and then you try to diagnose the sac. So you do a TVS here, 1000 आया, you do a TVS here. Three things can happen. If you see an intrauterine pregnancy, happy, send them home. You see ectopic pregnancy, manage ectopic, like how you have to manage according to the beta-hCG level. Or if you don't see any sac, you still manage them as ectopic and give a methotrexate. Why? Because your beta-hCG is increasing. You never know, you might be dealing with one ectopic. Or abdominal pregnancy or pregnancy of unknown location. So better to give them a methotrexate dose and then follow up for the decline of beta-hCG. All right. So next, when you have an ectopic sac seen, what it can be. So either it is an ovarian ectopic or it is extra-ovarian ectopic. Now, for all practical purposes, ovarian ectopic is rare. Please understand, in your practice, you will not be fighting for rare entities. They will rarely come to you. You have to fight for entities which are common. So our extra-ovarian entities are more common than ovarian. Now, for ovarian ectopic, you don't have to see the adnexal. You have to see the ovaries. And you have to differentiate it from corpus luteum. That is it. So what will happen? आपको ovary में एक corpus luteum दिखेगा, उसी के बाजू में एक sac दिखेगा. Now these two can resemble. What if you don't get a yolk sac? You might see two similar kind of appearances. So this you have to judge wisely by correlating it with beta-hCG. Don't just label, if you see two things in the same ovary, don't label it as ovarian ectopic. Why? Because your ovary can have two corpus luteum at the same time. It can have two ruptured follicles at the same in the same cycle. So do not label. First thing, why? Because it is very rare. In fact, I have seen only one ovarian ectopic till date in my entire practice. And secondly, it is more common that the lady might have had two corpus luteum. The third, extra-ovarian things. Now, what are extra-ovarian ectopics? We again have three types. One is cornual ectopic. Third is tubal ectopic. Fourth is abdominal ectopic. So you have three extrauterine: ovarian, cornual, tubal, and abdominal. Now, cornual means again in the cornu. Now, these usually needs surgical treatment. Laparoscopy is the choice. Tubal and abdominal, you have to treat according to the level of methotrexate. Now, how do you decide medical management or surgical management? If at all the patient is stable, your beta-hCG is less than 5,000, FHR or pole is not seen, patient can follow up, and the mass or sac is less than 35 mm. These things you can still think of medical management, but any of these are not present, you have to go for surgery. Now, broadly classifying, how do you do medical management? Less than 1,000 beta-hCG, expectant, 1,000 to 5,000, either surgery or medically manage. More than 5,000, definitely surgery. All right. Now, when you see a normal sac, follow up after 7 to 10 days for fetal pole. When you see a fetal pole, follow up after 7 to 10 days for cardiac activity. This you have to remember. 7 to 10 days, you should give minimum time. Don't call them before a week. The latter you call, the better it is, because firstly, it saves money. Secondly, it reassures, if at all you give them a better answer. So if you see a normal sac intrauterine with a yolk sac present, for fetal pole and cardiac activity, you should not hurry. But then establishment of a normal sac should be done before that. Now, if at all you're not able to see the fetal pole and the cardiac activity, then what? If you see a sac and the size is less than 25 millimeter with absence of fetal pole and cardiac activity, you wait. Till what time can you wait? Till this sac becomes more than 25 mm. So when it is empty and it is more than 25 mm, then you label them as blighted ovum or a missed pregnancy. Similarly, if at all you have a sac and you have a fetal pole, but there is no cardiac activity. Fetal pole is there, but there is no cardiac activity. So till when can you wait? Till the time this fetal pole is 7 mm or less. If at all it outgrows 7 mm and still there is no cardiac activity, you declare them as missed abortion. When you see only sac, only yolk sac, wait for 7 to 10 days. All right. So here we conclude our entire topic of UPT positive. Now, all of these details, I have put it in a flow chart and I'll be showing you through PowerPoint. Just give me a second. So you have a UPT positive. It's just a summary of everything. You have a UPT positive and the patient comes pain abdomen, bleeding PV or nothing at all. You do a USG. Then you have presence of sac. If there is a presence of sac, you call it as intrauterine sac. If no, then you say it is an empty uterus. And you do an Adnexal evaluation. Now, if at all you have an intrauterine sac, then what you do? You make sure that it is a true sac. Or you have to differentiate it from the pseudo sac. Now, how do you do that? You see the yolk sac, you see the fetal pole, you see the interdecidual or double decidual sign. It's the same thing. Now, this is what is the double decidual sign. Now, this is the decidua parietalis. This outside one is the decidua capsularis, and the innermost line is the sac. So you can see actually 1, 2, 3 lines. So this is a true sac. Now, in pseudo sac also you need to do Adnexal evaluation. Now in pseudo sac, if at all you don't find anything in Adnexal evaluation, you have to follow them up for a true sac. Now, if at all you get a true sac, which is normal in location, you still need to rule out heterotopic pregnancy. Now, see, this is an example of heterotopic pregnancy. This is the uterus. You can see one sac inside the uterus and one sac with actually a fetal pole present in the Adnexal. This is your uterus. This is your Adnexal. So, two sacs you have to rule out even when you see an intrauterine pregnancy. Now you have a true sac, then what I told you, you have to see the location of the sac. Either it is centric or it is low lying. Now in centric, you have angular pregnancy, interstitial pregnancy, or the uterus is malformed, biconvate or septate. Then you might have an eccentric placed sac. Now in angular pregnancy, it is located well within the endometrial margins, but there is an increased risk of miscarriage and adherent placenta, but they can have a near normal outcome. And this is an angular pregnancy, if you can see. It is in the angles of the endometrium. You have to regularly follow them up. Now, interstitial pregnancy, you see an interstitial line sign. Thin rim of myometrium is seen around the sac. They have the worst outcome, torrential bleeding. They have to be dealt with early methotrexate or surgical exploration. Bicornuate uterus, you have to follow them up, but sometimes because the capacity of uterus is less, they might need a cervical encirclage. Now, if you have a low lying, either you have cervical, scar ectopic, or incomplete miscarriage. Now, cervical, you will have a hourglass shaped cervix. Internal and external halls are closed and vascularity is present all around the cervix. This is empty uterus with cervical ectopic with vascularity seen. The R-shaped cervix can also, or barrel-shaped cervix can also be seen. Now, in a scar ectopic, you see empty uterus and cervix, right? Because it is in the area of scar. And internal and external halls are closed. Vascularity and deciduum is seen around the scar. There is a thin rim of myometrium. So, as you can see, this is the scar. This is a 3D image of the patient. This is the scar, and the sac has actually embedded in the myometrium. So this is a scar ectopic pregnancy. The third is the incomplete miscarriage, where the internal and external halls are open. Vascularity is not seen around the sac, and the sliding sign is positive. Cervical ectopic, you have to follow them up with methotrexate or surgical. Scar ectopic, if it is on scar or into the scar. Now, on scar, USG guided aspiration. Into the scar, because it can rupture, you have to go into surgery. Now, the case which we saw was into the scar. Incomplete miscarriage, you have to do aspiration. All right. Now, something called as intramural. It happens very rarely when you have pushed the sac too hard, scarred the uterus, and the IVF was difficult. This happens very rarely. There might be an intramural pregnancy. Now, in case of Adnexal evaluation, you can have Adnexal sac seen with fetal pole or yolk sac present. You know, definitely it is an ectopic pregnancy. You don't see a sac, but you see Adnexal mass. The third thing is there is no Adnexal mass. So you label them as PUL. Now, PUL, you see beta-hCG doubling time. It is falling, failing PUL. If it is rising, intrauterine pregnancy. If it is in between, most likely ectopic. Now, intrauterine pregnancy, you do a serial hCG till it is more than 1000. Then you locate the sac. If it is failing, you do weekly beta-hCG till it is less than 10. And in ectopic, you do beta-hCG monitoring and you see the hCG till it is more than 1000. And then you repeat a TVS to locate the sac. Now, if the sac is in intrauterine, you label it as intrauterine pregnancy. If it is seen extrauterine, you label them as ectopic and then manage accordingly. And if at all there is negative TVS, you might want to label them as PUL and then you medically manage them with methotrexate. Now, in case you have Adnexal mass, confirm ectopic. And if you have a confirmed ectopic or a suspected ectopic according to Adnexal mass presence. All right, so for example, this is an Adnexal mass. You see that there is a mass, but there is no sac seen separately. All right, so this might raise the suspicion of ectopic, but we are still not sure that if it is ectopic. All right, but if you have a confirmed ectopic, it can be either extraovarian or ovarian. Extraovarian can be tubal, abdominal, or cornual. Cornual you have to manage surgically, and tubal, ovarian, abdominal, or suspected ectopic. Your treatment depends on the level of beta-hCG. Now, we'll just revise the beta-hCG. If the patient is clinically unstable or FHR is present, Adnexal mass is more than 35 mm, can't come for follow-up, beta-hCG is more than 5000, surgery. Salpingectomy is preferred. Salpingotomy you have to do when the contralateral tube is damaged to save the fertility of the lady. Anti-D you should give if the patient is Rh negative, if you have done a surgery for the patient. Now, if at all the patient is stable, FHR is not seen, Adnexal mass is less than 35 mm, and she can come for a follow-up, then you see the beta-hCG level, less than 1000 is expectant. If the value drops by 15%, then you can confirm. You have to see the beta-hCG on day 2, day 4, day 7, and then weekly. That is when the value, till the value drops till 15%. And it is less than 20, then you send her home. Now, if your beta-hCG is between 1500 to 5000, you give her a methotrexate or surgery depending on the condition. Then you follow her up day 4, day 7, and weekly. If there is a rise or plateau, then you have to go for the surgery. If the beta-hCG is less than 1500, then expectant surgery or medical, you have to decide either according to the patient. Thank you so much. If anyone has any question, can please put it in the chat box. We'll try to solve them. I know it is a difficult topic, little too much, but then it is practically very useful. Keep revising. If you do it 1 or 2 times, it will become very easy. All right, if no questions, then definitely people can ask me later. I'm always available to solve your queries. Shall we conclude? All right, see you guys later. Have a very good night.